recently, there have been two somewhat conflicting recommendations about how to deal with our patients who are on incretin hormone therapy before undergoing elective surgical procedures. So, first off, the FDA has updated the package inserts for all of these incretins, meaning the GLP-1 receptor agonist and the dual GIP GLP-1 receptor agonist, or tirzepatide, with a warning about pulmonary aspiration during general anesthesia or deep sedation. And they instruct patients to let healthcare providers know of any planned surgeries or procedures. And this has come because of post-marketing experience in which patients who are on GLP-1 receptor agonists have had residual gastric contents found despite reported adherence to preoperative fasting recommendations. Now, the problem with this is the FDA says that they don't really actually know what to tell us to do or not to do because we don't have knowledge as to how to truly mitigate the risk of pulmonary aspiration during general anesthesia or deep sedation. They don't know if modifying preoperative fasting recommendations should be changed, if temporary discontinuation of the drugs could reduce this problem. They really don't know what to tell us to do, except for to tell us that this is a problem that we should discuss with our patients. So at about the same time, a society guideline, and this was a number of different societies that included the American Society of Anesthesiologists, stated that most patients should continue taking their GLP-1 receptor agonist before elective surgery, which struck me as somewhat discordant from what the FDA said, although the FDA also says they don't know quite what to tell us to do. But this clinical guideline goes into a bit more detail. And what they think might be a good idea is that in patients who are at the highest risk for GI side effects, should follow a liquid diet for 24 hours before the procedure. So they basically look at who is at highest risk, and they say the following. They say that patients in the escalation phase of their incretin therapy, that is early in treatment when the dose is going up, are most likely to have delays in gastric emptying because that effect is lessened over time. They say that the elective surgery should be deferred until the escalation phase has passed and the GI symptoms have dissipated. And they're very clear that patients who have significant GI symptoms, including nausea, vomiting, abdominal pain, constipation, shortness of breath, should wait until their symptoms have dissipated. And they think that this is something that would be good no matter what dose of drug these patients are on. But they do say that you tend to see more in terms of issues with gastric emptying at patients in the highest dose of a GLP-1 receptor agonist therapy. And they also mention other medical conditions that may slow gastric emptying, such as Parkinson's disease, which may further modify the perioperative management plan. So their proposed solutions that sort of correspond with my proposed solutions is assessing the patient. And obviously, if a patient is going up on the dose of these drugs or having a lot of GI side effects, that's someone that you probably don't want to send for elective surgery if you don't have to. But if you do, and possibly in everybody, you might want to withhold the drug for 10 to 14 days preoperatively, make sure they don't have significant GI side effects as they're preparing for their procedure. One of the things the anesthesiology group was worried about was that glucose levels would go up and patients would have hyperglycemia going into surgery. But I'm not so worried about holding a dose or two of one of these agents. I don't see a lot of hyperglycemia occurring. If it does, you can treat it in other ways. Then if it's somebody where you think that they are having symptoms, but they want to have the procedure anyway, you can put them on a liquid diet for 24 hours or so that there's less of a risk of retained gastric contents, at least gastric solid contents. Anesthesiologists can help with this as well because in many cases they can do a point-of-care gastric ultrasound to check for retained food or fluid. I know this is sort of vague because I don't have clear recommendations, But I do think that it's important to talk with your patients to assess whether or not they're having signs or symptoms of gastroparesis. I think it's not unreasonable to hold the incretin hormone therapy for 1 or 2 doses before a procedure if you have that opportunity. And then to be sure that the anesthesiologist and surgery team is aware of the fact that the patient has been on one of these agents, so they're a little more aware of the risk for aspiration. Thank you.